Mr. Chairman, today we have to talk about Evar outside instruction for use. At first, I want to thank my team at University of Bologna in Italy for this continuous encouragement. Evar is widely applied worldwide in the treatment of AAA because of minor invasiveness, lower pre-operative morbidity and mortality. Evar can be performed only in presence of specific anatomical conditions that are not present in the total patient. In 2002, Chekhov et al. Classify and identify and grade the factors that modify the outcome of endovascular aortic aneurysm repair. And he defines a hostile or challenging neck anatomy in patient with neck length less than 10 millimeter and with neck diameter more than 28 millimeter and neck angulation less than 120 and the classification or thrombosis of the proximal aortic neck more than 50% of the proximal neck. Each manufacturer device has its own instruction for use, like Vascutek and Gore and Medtronic and Cook, which included in our study. As you can see in this image, this is a proximal aortic neck with femoral anatomy, and this is photos with proximal aortic neck with a challenging anatomy, angulation, and short neck and more diameter more than 32 millimeter. In 2008, first published a study about the instruction for use outside instruction for use, and they include 560 patients, and they conclude that application of the Evar outside instruction for use have increased negative effect on late result and indicating that the adherence to such instruction for use guidelines is appropriate in our clinical practice. Then in 2011, another nice work from Charlton in USA, they report 258 patients with preoperative complication rate where 3% for friendly neck anatomy versus 16% for hostile neck anatomy with statistical significance. So they conclude that hostile neck anatomy can be treated with Evar, but with higher rates of early intraoperative type 1 endoleak. Then in 2013, another study from Lee et al., which published in European Journal of Vascular Surgery, they include 280 patients and 18 patients, and they conclude that suprarenal fixation and aggressive use of proximal cuffs is associated with optimal result when to use Evar outside instruction for use. Then in 2015, another paper published in the Journal of Vascular Surgery and include 489 patients, and they conclude that there is no significant difference regarding long-term follow-up or overall mortality and aneurysm-related mortality if IFU not adherent in the group population. In 2016, another study included 560 patients undergoing Evar, and they report aneurysm-related mortality and all-cause mortality similar between the two groups. Then finally, in 2018, another study that recommend not to use Evar outside instruction for use, as any instruction for use violation was significantly associated with graft-related adverse event over the time. A systemic review and meta-analysis, which published in 2013, concludes that there is insufficient high-level evidence for or against performing standard Evar in patients with hostile neck. Regarding the European Society guidelines, which published in 2019, they report that outside instruction for use devices may have medical-legal implication in some countries. In our study, we include 591 patients during the period from 2012 to 2018. And we divide our patient into two groups, Group A outside instruction for use and Group B inside instruction for use. Our early endpoints were technical success, perioperative complication, and 30-day morbidity and mortality. Our midterm follow-up endpoints include overall survival and freedom from re-intervention. Regarding our result, regarding the patient demographic and associated comorbidities, there is no difference between the two groups apart from that outside instruction for use group were older and more females. Regarding the outside instruction for use group, we violate the only one character for the instruction for use in nearly 80% of the study population, and nearly in 128 were with neck angulation more than 60%. Our overall technical success was achieved in 578 patients with no statistical difference between both groups. But regarding the proximal neck technical success, there is a statistically significant difference. Type 1A embolic was detected in couple of patients of inside instruction for use group, one converted to open surgery and one managed conservatively. In outside instruction for use group, 4 patients have embolic type 1, type 1A, 2 treated with cuff insertion, 1 with fenestrated Evar, and 1 followed conservatively. Intraoperative complication, there is embolic 1A with a statistically significant between the outside instruction for use and inside instruction for use group. Our early 30-day morbidity and re-intervention rate and mortality was the same between both groups. Regarding the survival, using log-rank p-value, there is difference between instruction for use, statistically significant between instruction for use group and outside instruction for use group. Regarding the freedom from re-intervention and midterm follow-up, there is no difference, no statistical difference between both groups. So we conclude that in challenging circumstances, patients with hostile neck characteristic can be effectively treated with Evar, and we recommend in these patients proper oversizing and operator experience and close follow-up are recommended for these patients. Also, adjunctive maneuver like proximal cuff insertion are advised for proper outcome. And thank you.